In progress.
In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening, colleagues, and welcome to Clinics Indeed, where health and care meet. We are meeting again this evening on this Mandela Day as we celebrate the birthday of Akon Madiba, and people participate in various kinds of social activities of goodwill. And we also know that there's opening of Parliament this evening, so we hope that you will stay with us until the end and won't keep it that long until just after 7 o'clock. This is our weekly webinars, and we are excited to have you back with us and also bringing back one of our esteemed professors and academics, clinicians, Professor Koto, in our midst that you all know. Please note that this, as usual, these webinars are CPD accredited, and so we need to get your full details when you register, so that we can upload your information and give it to the HPCSA. And we hope that you are getting your CPD points allocated, but as usual, those who are having challenges, let us know, and we'll assist as much as we can. And these webinars are also streamed live on YouTube, so at any time when you wish to go back and check the previous presentations, you are at liberty to do so and check them. And even this evening's webinar presentation will be on YouTube. And so this evening, we're excited to bring back Professor Koto, who is well known to most of you. I don't have to go through the CV. He's an esteemed professor of surgery, a fellow of the Colleges of South Africa, and also fellow of the American College of Surgeons. And he's also a top specialist in laparoscopic surgery, and also a member of a number of colleges within Africa. And he's also an academic head of department at Health Sciences University, and also a member of our health committee. So excited to bring back Prof. Koto, who will be talking to us about the septic abdomen. And thank you very much, Prof. Koto, for always availing yourself to speak to us on these webinars. So we look forward to another engaging discussion on one of your passions. Welcome.
Yeah, thank you very much, Dr. Bila, for your kind introduction, and thanks to the clinics group for this opportunity. And thanks for everybody who's around so that we can share, just my thoughts around, this very important topic, which is septic abdomen. I don't know if is my audio clear? Can you all hear me?
Yes, we can hear you, Prof.
All right, thank you very much. Yeah, this is what I hope to cover in today's talk. Just maybe a brief introduction, just to sketch, the landscape of sepsis and management of sepsis over the years, where we come from, where we are at the moment. Just maybe to touch on the definitions, because sometimes we talk about, peritonitis, we talk about sepsis. This the same thing or different. Clear that, and then classifications of abdominal sepsis, peritonitis, and I'll spend a little bit of time on the pathophysiology of the septic abdomen, and then the treatment, which is really the cornerstone of management of this potentially deadly condition, and then focus a little bit on the surgical management and currently what is the recommendations as far as that is concerned. Bacterial infection, it was really horrendous, 90% almost. 9 out of 10 patients, never made it. And this was really largely because this condition was managed non-operatively. It was really until, Kirshner and his co-workers introduced the basic principles of surgical management of intraabdominal sepsis, which is really focuses around eliminating septic foci, removal of necrotic tissue, and drainage of fluid material. Of this patient from a dismal 90% mortality rate, that mortality sadly came down, and by the 1930s, mortality had come down to around 50%. And certainly with the introduction of antibiotics, mortality continued to decrease. Now, that being said, there are skeptics, however, who really have argued, whether or not indeed there has been a decline in mortality, but is it really this dramatic, as dramatic as
Yeah, it looks like we've lost Prof. Koto. We'll just quickly check with him. Hopefully he'll log back in.
Hi, Prof. Are you there?
Hello, can you hear me?
Yes, Prof. We can hear you.
Oh, sorry. Yeah, I think there was
If you
something
can,
that went wrong. Yeah, thank you.
yes, if you can go back to your presentation again, Prof.
All right, let me show it again. I'm not able to share my screen. This is Labadu Sync screen. So I'm going to try again to.
We see the Zoom connection. Maybe if you are able to move out of that.
Can you see my screen now?
We just see that you are. It shows us the Zoom page.
Share screen. Say you cannot start the screen whilst the other participant is sharing. So that's the message I'm receiving. I think somebody is sharing the screen.
Maybe it's on your side. If you close the other screen on your side.
Okay.
Maybe if you log out and log in again, and let's
okay.
see. Yeah, I think log out and log in again.
Okay, I'll try again. Let me.
Hi, Prof. You can try and sharing it now again. Let's see.
Yeah, it's showing now.
Showing. All
Yes.
right. Okay. All right. Thank you. Thank you. Yeah. So thank you very much. You know, again, there has been a number of reasons as to why there's been a decline in mortality. The one reason certainly has been the adoption of cephalosporin of the physiology of sepsis, the close monitoring of these patients, support of cardiopulmonary system, certainly the better ICU care. Now, in terms of definitions, peritonitis, intra-abdominal infections, abdominal sepsis, they are not synonyms, and yet they are used interchangeably to define similar clinical states. Peritonitis is really defined as inflammatory process virus, drugs, granulomas, foreign bodies, as opposed to intra-abdominal infection, which is really defined as the local manifestation that occurs as a consequence of peritonitis. And intra-abdominal sepsis entails really a systemic manifestation of severe peritoneal inflammation. Now, the clinical spectrum peritonitis may certainly be classified, as according to the pathogenesis as primary. It can still be classified as secondary or tertiary peritonitis. Secondary is certainly the commonest type of peritonitis. Now, in terms of pathophysiology, as we all know, anatomically, the peritoneum is covered by a monolayer of mesothelial cells. This monolayer has got a basal laminar sub-mesothelial stroma, and certainly creates a semi-permeable membrane, or barrier through which water and solids can passively exchange. Now, if you have large particles like bacteria, that are concentrated around the diaphragm area, and the rapid removal of intraperitoneal microbes by these lymphatics is certainly central to the pathophysiology of abdominal infections. Now, if liquids are mostly solutes, within the peritoneal cavity, easily pass through these mesothelial cells. However, when you have large particles, these are eliminated through the larger orifices.
Thank you.
That are
Hi, Prof. We can't hear you again. I don't know. The video was switched off, but the audio should still be working, but it's not. So, colleagues, we're trying to sort out something with Prof. Koto is that is a very poor bandwidth. So, but we will give us time short, we will sort it out.
Mm. Green.
Not yet.
Prophet Skamu, please try and sharing your screen again.
Yeah, is it showing now? Is my screen showing?
Yes. Yes, now it's
Thank you.
showing.
All right. My apologies for that. Yeah, so my internet.
Yeah, you can go ahead, Prof. I'm not sure if you go ahead, we can see your screen, but perhaps if you shall we try to sort it out, colleagues, so about that. But unfortunately, the presentation is quite a large, and to share it and to send it to us via email, it's a bit of a challenge, but we'll see if we can still do that.
Yeah, my apologies once again. I'm back. So I'm gonna try again to share my video. Can you see my screen?
Not yet.
Not yet.
Yeah, I think.
Yeah, it's coming.
All right.
Yeah, sure.
Yeah, my apologies. I think I have an unstable network there. Yeah. You know. is really characterized by usually this hyperemia that occurs, and there's increased exudate of fluid macrophage into the peritoneal cavity. Now, in these initial stages of peritonitis, there are predominantly macrophages that move into the peritoneal cavity. Now, neutrophils will arrive, within about 2 to 4 hours, and eventually they become the predominant cells in the peritoneal cavity by the first 48 to 72 hours. Interleukin-6 and tumor necrosis factor, leukotrienes, platelets activating factor, and so all these combined effects, of these mediators, they all contribute to observed inflammatory response that we see with peritonitis. Now, as a consequence of this inflammation, there's usually production of fibrin or fibrinogen, in the septic foci, and this create a mesh, of fibrin, cavity, and this certainly helps to trap bacteria. And this phenomena may generate, if not control, formation of an abscess in the peritoneal cavity. And in addition, there may be momentum also that migrates towards the inflamed area. And all this certainly helps in delivering mediators and serves to facilitate, abscess formation. Often this, the most common site really is the subphrenic areas. Recognized by these so-called pattern recognition receptors of the innate immune system in the body. And then indirectly via molecular release from the injured mesothelial cells, the initial stages of the response depends on a number of things. And one of those is influx of macrophages, production of pro-inflammatory cytokines, including the ones that I've mentioned, tumor necrosis factors, and the other cytokines that I've already mentioned. As I said, neutrophils are the first one to bacterial destruction. They release a number of things like liposaccharides that are released, other cellular components. All of these further stimulate the host pro-inflammatory response. This is just a table in one of the publications basically looking at the origin of peritonitis by site. If you look at the stomach, duodenum, the biliary tract, the small bowel, appendix, colon, as you can see here, certainly appendix is by far now peritonitis can be potentially deadly, and certainly there are certain determinants of mortality, things that help or help fuel the cascade towards mortality. And one of those patients' age, the elderly patients certainly don't do very well with peritonitis. If patients have a pre-existing disease, comorbidities, cardiovascular, liver disease, renal, certainly those patients don't do very well. If there is certainly certainly if you don't treat these patients early on, usually outcomes are not very good. And of course, the extent of peritonitis also certainly determines whether or not patients will end up as mortalities. Now, this is one of the patients that we treated. As you can see on this picture here, this is very dense fibrinous exudate, very extensive fibrinous exudates. And this certainly looks very, very ugly, but in terms of immune intervention, one has got to remember that this certainly may be beneficial to the patient. Free fluid certainly should be cleared. Peritoneal cavity should be offered extensive peritoneal toilet. But I think one should refrain and resist, the temptation to remove this, ugly-looking fibrinous as it is beneficial to the patient. So I'm just going to go now again. As I said, it's certainly a deadly condition if not treated properly. appropriately. There are certain physiologic derangements that can occur. Certainly there are inflammatory variables that occur, hemodynamic changes, organ dysfunction changes, and tissue perfusion changes. When you look at in terms of general variable, the temperature certainly will go up. In some instances, the temperature may be low if there's extensive sepsis, and they tend to have an increased heart rate. And of course, a significant edema, and they often have a positive fluid balance overall. And there are certain inflammatory variables that occur. They may have leukocytosis, the white cell count may go up. In some instances where there is overwhelming sepsis, certainly they may have leukopenia. Some of these patients, the inflammatory markers go up, C-reactive protein certainly goes up, procalcitonin and also go up. There are certain hemodynamic changes that occur. Also may be low. And these patients, if you look at their arterial blood gas, they may show a picture of arterial hypoxemia. In terms of urine output certainly may be decreased. And of course, renal dysfunction as well. Creatinine may rise. They may have coagulation abnormalities. Activated partial thromboplastin time may increase. The INR may also go up. In terms of bowel function, they may have ileus as a result of sepsis. And of hemodynamic changes that occur. In terms of tissue perfusion, certainly they have increased lactate. Often the lactate goes up. There's often decreased capillary refilling, or the skin may look or may have signs or show signs of mottling. Now, how do we then classify peritonitis? Now, the classification is primary or spontaneous peritonitis. I'll talk a little bit about that. The secondary peritonitis is really the commonest one. The vesicular perforation, appendicitis, and many other causes. And of course, post-operative peritonitis or peritonitis as a result of trauma, and then tertiary peritonitis. Now, the primary one is really an inflammatory or inflammation of the peritoneum by an extraperitoneal source. Often this occurs as a result of hematogenous spread. Typically, it occurs in young children. In adults, that are receiving peritoneal dialysis. And typically, it has a single microorganism, or it's mono microorganism. And the main pathogens in adults are usually the coliforms. If you look at majority of these patients, 70% of the infections are caused by E. coli, and then there may be others. And how do we then manage these patients? Management include, they usually don't operate, usually include antibiotics. This patient, usually the operation is usually often where the diagnosis is in doubt, where we would offer them a diagnostic laparotomy, or in this day and age, we would offer them laparoscopy. And often what we will see is a characteristic purulent material which will have gram-positive cultures, without obvious perforation or abscess in solid organs. This is how certainly they present. Now, the secondary peritonitis, this one is the commonest. This is the one that we see.
Dr. Have it on mute or unmute?
We seem to have lost you again, Prof. Koto. Yeah, I think we're losing him. You'll have to bear with us, colleagues. He's got a very bad bandwidth. That's where he is. So we might have to be having intermittent interruptions until we finish the presentation. Please bear with us. He will join us soon. So colleagues, Prof. Koto will be rejoining us soon. Let's give him some time. And it's a bit irritating when it happens like this, but it's one of those technical challenges we have with Wi-Fi and network connectivity these days.
The host has disabled my screen sharing. If you just allow me to screen share. Yeah,
I'm
now it's
sure.
okay.
Okay,
Yeah,
there we
all
go.
Yeah, all right. Yeah, once again, my apologies. And my internet is very unstable. My apologies to everybody. Yeah, that's right.
Sorry, Prof. Please share again.
Okay.
Thank
Is
you.
it better now?
Yes, it's
Okay.
fine. Thank you, Prof.
All right. Yeah, so I was just talking. Okay, now my screens, now my slides are not moving now. Let's see. Oh, yeah, that's right. Yeah, these are the common, causes of secondary peritonitis. As I said, postoperative. You know, and usually the anastomosis, usually, the leak occurs around, day 5 to day 7 postoperatively. These are the patients who will not settle after surgery. They will, they do not follow the expected post-op course. They may have, raised inflammatory markers. Their abdomens don't settle. They have abdominal tenderness. They have delayed bowel function. Expected post-operative course. Usually something is not well. So these are the patients that you would investigate, assess them properly, offer them cross-sectional imaging to see if they have anastomotic leak or not. And the post-traumatic ones also, these are the patients who will come in, with generalized peritonitis, and then we then manage them accordingly. Now, what is tertiary peritonitis? Now, tertiary peritonitis is defined as, persistence or with primary or secondary peritonitis, if they have completed adequate surgical antibiotic treatment and the infection still persists, this is what we would call a tertiary peritonitis. And those patients certainly that have had, multiple interventions, certainly after third intervention, and they still have sepsis, would consider them as having a tertiary peritonitis. Now, the microbiology in tertiary peritonitis, they will have an ongoing organ dysfunction. Certainly, this should indicate that there is inadequate drainage of unidentified focals. Certainly, these are the patients of, or this kind of presentation is seen typically in patients that are immune suppressed, and the patient is often very septic, and they will show, features of sepsis, which is hyperdynamic cardiovascular state. They may have fever, certainly may have failed, to improve. Rather, what you see is really diffuse exudate, and often there's not fibrin purulent membranes that we see typically in secondary peritonitis. And there may certainly be fluid which is less clear. And then when you culture this fluid, often it reveals coagulation negative staphylococcus, sometimes enterococcus. There may certainly be pseudomonas, in some instances yeast or enterobacter, among others. To percutaneous drainage. And then certainly they are very difficult, to locate within the abdomen. Now, when you go to theater, the inexperienced surgeon certainly may describe this as, we found, serosanguinous fluid in the peritoneal cavity, and we think the abdomen is certainly clean, and this is certainly a major mistake, that, once you see serosanguinous fluid in these patients, usually, it suggests aggressively fluid antibiotic therapy. But often what happens, these patients are labeled as a clean abdomen and they're offered, closure, and only to develop, a rapid deterioration afterwards, tachycardia, hypotension, bacteremia, and often organ dysfunctions, which may certainly lead to mortality. So what is important, therefore, is really to aggressively manage, the immediate postoperative period, and certainly
Yeah, it looks like it's going to be the order of the day until we get through the presentation. I trust that you'll have the patience to stay with us because of as said, that it's got a very unstable network. So we just give it some time again. Once more, we'll get through this. We'll definitely get to the end. Just bear with us.
my apologies. Sorry. As I said, the treatment of this patient really requires, a multidisciplinary approach. The surgeon needs to work with the intensivist to manage this patient. When the decision, is made, to re-explore this patient, because of deterioration, certainly require monitoring of intraperitoneal pressure to prevent, abdominal compartment syndrome. Once they are adequately resuscitated, they need to be taken back to the operating room. Now, this is really has been really the cornerstone, of guidelines that assist us in managing this patient. The Surviving Sepsis campaign, just maybe a few pointers, again, they suggest that this patient should have a measurement of their blood level. The antimicrobial should be started, immediately, certainly within the first hour. Antimicrobial should be started for this patient. In terms of fluid, they suggest, about 30 mils per kilogram of fluid. This is really a contentious issue, and many people have argued that, the Surviving Sepsis campaign, the data comes from well-resourced countries, different from what we are accustomed to in our environment, and that 30 mils individualized. And the goals of resuscitation of these patients, we would really like to have a central venous pressure line, 8 to 12. Again, goal-directed, therapy. Again, there's a lot of argument around that whether or not it's the appropriate way to go. But certainly the MAP, mean arterial pressure, above 65, and we're really aiming to have the urine output at least 0.5 mils per kilogram per hour. So I think it's important really to and of course the glucose, quite closely. Now, in terms of antibiotic therapy, antibiotic therapy should be initiated as soon as possible, and this is certainly the recommendation of Surviving Sepsis campaign. And it's important, again, hang time, that antibiotics are started early on. It has got a mortality benefit if you start your antibiotics early on. And usually, the choice of antibiotic initially is administered on an empirical basis, because usually they have the gram-negative. Certainly, these are sensitive to cephalosporins and penicillin. But of course, one should not forget, the fungal sepsis, certainly in these patients here. So we would certainly start them, especially those that have severe sepsis, on antifungal therapy. Now, where there is moderately or community-acquired, peritonitis, certainly sulfobactam or etapam certainly may be appropriate in this patient. Now, the first line of therapy may differ, from one institution to the next. But however, it may include, anti-anaerobic medications such as flagyl or clindamycin, and then combined with aminoglycoside in selected cases. Where there is severe sepsis, patients really who have the high risk of nosocomial infection, initial monotherapy with piperacillin, tazobactam,
Looks like we're losing you again, Prof. Yes, we are. Yeah, we lost him again, and so he, as we've been doing throughout this presentation, logging. We apologize for this. We didn't anticipate this, and as we said, we were trying to ask him to send us the presentation, but he said there's a large video. We are not able to do so. But in the meantime, may I also request that, colleagues, there is no need to post your MP number, any SANC number, anything of that sort on the chat line. Because when you registered, you gave us your name. We hope that you did give us your full names and the full registration number and your email address, and all this information that you provided has been captured and will be then sent to the HPCS. So there's no need to to redo it once again. Thank you very much for your patience. Prof. Koto is back once more, so we'll continue with the presentation.
Thank you very much. My apologies. I think my internet today certainly has behaved, big time, and my apologies to everybody for that.
No
Yeah.
problem.
So we're just talking about the antibiotic, and then in terms of surgical management, now the goals of surgical management are: firstly, we want source control. We want to get source control. We want to reduce bacteria. This is how it looks like. Often these patients, certainly, this is what you see. You see that fibrinous exudate. And this is a patient who had a perforated ulcer disease. Again, important, to making sure that, you get source control. In this particular patient with a perforation, as you can see here, he's got a perforation. It's a very large perforation of the ulcer. We were worried that, this may certainly be malignant. Peritoneal canal. As you can see, it looks very ugly there. If you look at that peritoneum, again, leave that alone. It is, it looks, it's not pleasing to the eye, but actually it may have a beneficial effect to the patient. So free fluid should be cleared. That fibrinous exudate, that membrane, leave it as it is, and it actually has got a very, hugely beneficial role to the patient. Now, this is one of the patients that certainly we manage. Again, very
Yeah, we seem to be losing again, Prof. Koto. We are close to the end, colleagues. Thank you for being there still. I mean, there's still lots of you still waiting, and we are almost right at the end of the presentation. So bear with us, and we will definitely get to the end, and we will have more time, hopefully, for more engagements and questions. But in the meantime, please do post your questions on the chat line. And if there's any question, that we'll be able to deal with them once Prof. Koto has gone through the presentation. And we should be able to do so. Please stay with us. Don't go. You know the song. Please don't go. Stay with us. Let's give it a few more minutes, and we hope that Prof. Koto will be joining us again and complete the presentation. We apologize profusely, as he's been saying that there's this problem of the network. Very unstable, as we said, but we'll get there. Can I just see by just a wave of thumbs to say you are with me and you understand the problem? Just the reactions, just send your thumbs up and say no problem. Anyone?
Yeah. I think I'm back again, and I don't know if you
Thank
can
you,
hear me.
Doctor. Thank you very much. Yeah, we just get promoting the thumbs up sign to say we are with you.
Okay.
It will soon be over.
Yeah. Sorry about that. Yeah, I think it's just not a very good. Yeah, here again is irrigation of peritoneal cavity. So I'm just going to go, again, after you've done, the uses of drain is a controversial area, whether one should use a drain, as there's really no level 1 evidence to support routine uses of drainage. But these patients, especially these ones who come with a tertiary peritonitis, with extensive, very established peritonitis, certainly would leave a drain, especially those that have a perforated ulcer, who have done a laparoscopic repair. Compress.
Thank you for those thumbs up. It shows that you understand our dilemma this evening. Please continue sending them so that we see that you understand our problem, but we'll deal with it. Thanks for the questions also that you see, Dr. Nevondo, and we'll be able to deal with it. And please do that. Thank you very much. Keep on doing that, colleagues. Let's see more of you. There are more than 500 of you. So more thumbs ups should be coming. Thank you. It's coming. Let's continue with that. At least you'll see your name on the YouTube coming up with the thumbs up when you watch. And thanks for those who are saying that they understand that they will watch the presentation on YouTube. And at least when you do that, you'll be, at your leisure, and you'll be able to see that. And thank you very much, colleagues, for those thumbs up.
Yeah.
Prof. Koto is back.
Yeah.
Let's continue.
Yeah, I'm back again. Yeah, my apologies once again. Now relook on demand, or planned relook, where the relook on demand, where the symptom described, maybe a manifestation of a systemic inflammatory response. Now, what are the advantages, where we have decided relook on demand on the basis of the patient not improving, is not getting better, where there was sepsis, ab initio. So this is the patients where you would certainly consider relook on demand. And the advantages are that patient is not submitted or subjected to unnecessary surgery or anesthesia. However, the disadvantage that when reintervention is done late, certainly the underlying patient's physiology may be compromised, as opposed to a planned relook. Now here is where the decision to re-explore the abdomen is made for a planned relook. For example, if there's a failure to obtain adequate control of the source of sepsis during the index operation, certainly a planned relook is appropriate in that instance. Where there's inadequate poor drainage, or there's diffuse fecal peritonitis, or patients that have hemodynamic instability, or sometimes you want to reassess the anastomosis, or the patient may have intra-abdominal hypertension. So those are the planned relook. Now, if you look at, on a head-to-head of
Yeah, I think we are. Yeah, thanks, Dr. Masopa, for that comment that connectivity is always a problem in our country because of cable theft, etc. And Bob should not stress, and we should not stress also. We understand. Thank you for that reassurance. It's a very important topic. Yeah, we'll try to get slides. I think also what we'll propose to Prof. Koto also is to see if we cannot ask him to re-record this at his leisure, and then we'll post this on YouTube. Because maybe even on YouTube you might still get these interruptions, but it's something that we can consider. I'll see if we cannot talk to him to record this this wonderful presentation. It's an important topic that is presenting, and so if possible, we'll still keep the one that we have now, but we'll ask him to record the whole presentation without having to connect on Wi-Fi. But then we will definitely have this available as a presentation that you'll watch it uninterrupted. But for now, let's continue, and I thank you very much for understanding that you've been with us, and we thank you very much for your patience. We hope the state of the President will talk about how to solve the problem of cable theft in our country. Thanks, Prof. We're back.
Yeah, so in conclusion, severe secondary peritonitis certainly, or sepsis, is an entity that continues to carry significant mortality. Despite advancement in ICU care, antibiotics, surgical strategy, critical care support, antibiotic therapy, the mortality still is significant.
Prof. Koto, I'm going to put you. Don't worry about reconnecting. What I will do, I will call you on your phone, and then you can take questions. Okay, let me call him. I think rather let me put him on, and then we can talk to him on direct without having, because we've come to the end of the presentation anyway.
Hello, Ray.
Yes, Bob. You know what I suggest? Because we've come to the end of the presentation. Yeah. So what I'll do? Don't reconnect. Let's take one or two questions. They can hear you. Yeah. You can. Yeah, Dr. Kekana, you can hear Prof. Koto. I see your hand is up. Go ahead.
Good evening. Thank you so much, Prof, with the presentation. Thank you so much. I wanted to ask you, we're talking about
Prof. Koto, can you? Oh, yes.
Yeah. Now, I've solved the call.
Yeah, but I was going because you might log off again, because I thought maybe you should just handle this on the phone. You don't have to reconnect.
Oh, okay. I think I'm already connected. Yeah, but I can hear them. Yeah, I'll just go to the phone. Yeah. Please go ahead.
Yeah, when you drop, please don't reconnect. We'll just use the phone.
Okay.
Dr. Kekana?
Okay, I was saying thank you so much, Prof, for the presentation. Thoroughly enjoyed. I wanted to ask you, you were going on, and we missed you about the relook on demand versus planned relook, and which one comparing head to head is better. I stand to be corrected, but I think your department did a study, and then you showed that in terms of resources and in terms of the money spent, the on-demand is better than planned relook, because planned relook you can have non-therapeutic. Am I still right, or how is it now?
Yeah, no, I think you're correct. This is an age-old debate. Has got advantages. This relap, it was a Dutch multi-center trial, basically to answer this question. And the primary aim of the study was whether there was any mortality difference, and also on follow-ups, complications related, to these interventions. on follow-up. Yeah. Again, this study, they recruited more than 250 patients. Benefit. There was no mortality difference between relook on demand and planned relook. And also in terms of what was different, however, was resource utilization, ICU stay, and early discharge, and hospital stay. So the patients that were offered, a relook on demand, had less resource utilization. So I think if you had a head-to-head comparison, planned relook set. So which one should we do? Certainly, I think the one that certainly appeals in terms of advantages is planned relook. But that being said, there are certain subset of patients where certainly planned relook may still have a role. Patients that come with extensive fecal peritonitis, where you certainly again here is a judgment call. This kind of patient, should we be so. You could use it, but on demand. But planned relook, the advantages are that resource utilization is better. Am I still there? Can you still hear me?
Sorry, I was trying to sort that. There was another question from the chat line here by Dr. Navondo. So I'm trying to get to that question. Sorry, let me just get there. I was trying to copy it. Okay, let me just.
Technology, it works very well.
How does the
when it works well,
layer? Can you hear me? Yeah,
I can hear you.
How does the fibrinous layer differ from biofilm that forms osteomyelitis? Because it will be very tempting to scrape it off. That's the first question. And the second question is, okay, go ahead. Answer that one. I'll come to the second question.
This it's an acute, body reaction, basically to help, neutralize, the bacteria and also to trap bacteria in one place. But also, it's got immune cells. If you look at the macrophages within that fibrinous meshwork, there's immune cells that are there. But very importantly, in terms of barrier to neutralize, bacteria from spreading the body. So it's really a body comes there to basically contain the infection, which is different from a biofilm in osteomyelitis in terms of acute, response to an invading organism. And that is why, when we treat these patients, it is generally accepted that don't try to disturb that, don't try to disturb that membrane as well. But the loose fluid that is inside the peritoneal cavity is suctioned out. Now, washout again is study, firstly in pediatrics, for appendix rupture, whether, when there's peritonitis from appendix rupture, whether this patient should be offered a washout. So they did a randomized controlled trial. The one group received washout, the other group did not receive washout. There was no difference in mortality, no difference in outcomes. So now the question is it should really be washing out these patients? But that was a pediatric study, and there has been subsequent studies that have looked at adult population. There's one so really no benefit really to washing out this peritoneal cavity. The other one was a Chinese study, which seems to suggest that if you use large volumes of fluid, that may be some advantages in offering this patient peritoneal lavage. We had our own study, a randomized study that was done at our own institution. It was stopped prematurely because the patients that were offered washout actually had.
Okay, go ahead, Prof.
Currently, our standard of care is that if they come with peritonitis, we don't wash them out. Patient comes passing the abdomen, we simply suction it out, appendix, remove the appendix, we don't wash them out. And it's amazing how well they do, these patients. So there has been, some data which supports, non-washout of this period. So the washout certainly is one area of controversial, but there's patients, for example, that have a perforation from a peptic ulcer where there is intuitive sense in that setting to be able to wash them out, to neutralize, the acid that comes out of the peptic. But even in that instances, is it really necessary to wash out these patients? So I think it's an area that is controversial, and I suspect that as we move forward, more and more institutions will not offer these patients, washout, because the body has already done, remarkable amount of work in terms of neutralizing the offending organism that comes with peritoneal cavity. So when you wash out but it's a fascinating discussion. But be as it may, there's still surgeons that devotees of thorough peritoneal washout. Wash it out, and until the water is clean. But again, I think more and more a certain direction is swinging, or the pendulum is swinging towards not washing out, but simply suctioning these patients, suctioning the pus or peritoneal fluid, and not offering them lavage.
Yeah. Yeah, Dr. Novon, I'm not able to go to the second question because I see their colleagues with their hands up. Yes, I may use their question. Dr. Karen Pierre, if you can just unmute yourself. Can you let Karen Pierre to unmute themselves? Are still muted. Dr. Kekana, you want to make a follow-up?
Yeah, thank you so much. It's actually not a follow-up. I'm good with the first question. The second question that I had during the presentation was the use of drain. I know some surgeons would say they belong in the discovery center. But are we still advised to use a drain on a secretory organs, i.e. Perforated peptic ulcer? I know the breast is quite obvious, though we're moving away from extensive breast surgery, but are we still advised to use drains in the peritoneal cavity, Prof? Thank you so much.
Yeah, drains, thank you very much. Excellent question. Actually have data, one of our registrars, did as part of his MMed thesis, did a randomized study, randomized patients into drain and no drain, and again, no difference. But when you do a literature review, in preparation for the publication of that paper, there's paucity of data, published data in the usage of drains, but those studies that are available, really no difference, it makes the surgeon sleep better, but in terms of its effectiveness, it really doesn't have, a significant, effectiveness in terms of, draining whatever is. So I think today, more and more people really are moving away from drains. Now, if you saw there, I used a Wisha drain. That was a relook patients, who had leaked after a repair. So in other words, the patient had a the data to support that. The answer really, there's no data or high quality data to support routine usage of drainage in these patients. So I think the short answer to your question is, should you be using drain? I think it's a judgment call. If you feel, it makes you sleep better as a surgeon to put a drain, But is it really helping the patient? The answer Probably not. It's not really helping the patient. So I think it's left to the individual surgeons to guidelines. Again,
Yeah. I think there's another question. Are you still there?
right or wrong in terms of brain. Yeah.
All right. There's a question about open appendectomy as opposed to laparoscopic appendectomy, and then numerous relux. Why not just do an appendectomy? Is there a need for numerous relux?
Yeah, I think again, I suspect the person who asked the question asking complicated appendix, which can be localized abscess or open. Again, there has been a move, a shift towards minimal access surgery. Certainly, if the World Society of Emergency Medicine guidelines are very clear on this, and they recommend laparoscopic surgery if there's enough skill set. The surgeon does have a skill set or expertise to do laparoscopy. That will be the first port of call. Offer the patient laparoscopy, provided you have the requisite skill to do it safely. Not there, then the second option certainly would be to open operation. So the open operation, and certainly I come from that era where we used to do open operations, and it is now laparoscopy is a far cry from this open operation. Open operation, they have septic abdomen, wound dehiscence, and all sorts of problems. But long term, incisional hernias, and all sorts of problems, adhesive bowel obstruction going forward. So I think today, and this is access surgery to do it laparoscopically, it is hugely beneficial for the patient. It's amazing. They come with pus in the abdomen. You come in, you drain the pus, and then the next morning they're walking around in the ward. Is absolutely remarkable and dramatic how they recover very quickly. They're able to go home very quickly. But certainly there has been lots of studies, meta-analysis that shows advantages of laparoscopy in this setting. But once again, and the guidelines, this is the World Society or open operation. Now, you talked about a relook. Should we be offering this patient a relook laparoscopically? Absolutely. So this is what the patient has not settled. We would then offer the patient relook on demand laparoscopically. Once again, through the same ports, would go in. Of course, the key is to have cross-sectional imaging so that you can see where the collections are. It really provides you with a roadmap, the necessary roadmap to be able to see where to go. So cross-sectional imaging.
Hello.
Collection,
Okay.
you go again, laparotomy. You go laparotomy, relook, until when? Until now the patient the abdomen is clear. Now, as I said in my presentation, unfortunately the network was not good. Now when you relook this patient, there is this concept, the so-called serosanguinous fluid inside, especially those patients that they've had relook 3 times, 4 times, and then the surgeons tonight, and that is a patient that post-operatively should be in an ICU setting, fluids, aggressive resuscitation, because often what happens is that the abdomen is closed, they say it's clean, they go to ICU and suddenly they cascade downwards, the organ dysfunction, they suddenly, blood pressure is going down, and so you really want. So I think the key here was that serosanguinous fluid, which was considered clean when in fact it wasn't clean. And ideally should be the same person.
Okay. Okay, colleagues, I think due to time constraints and also that we had so many interruptions, and I see some people are logging off. I think it's because of the state of the nation address. If we still have a lot of questions, but I've captured those questions. So what we'll do, we'll ask you to we'll send you those questions that are remaining, and if possible, if we then ask that you respond to those questions in writing, then we'll post them to the colleagues. If it's okay. I
Thank you
think we've
very
lost.
much. Thanks.
Okay, no, thank you very much.
Yeah, no, that is fine.
Yeah, no,
Yeah.
thank you very much. I'm going to ask Prof. Wing just to do the closing remarks, then we end the presentation.
Thank you, Dr. Bela. Thank you for being a good chairperson and a good technician as well.
Thank
Prof.
you.
Koto, thank you for this presentation. As a physician, it's hard for us to pay tribute to surgeons. This is a historic issue, but as a physician, I will pay tribute to a good surgeon. What I liked is looking at this very difficult problem from a three-dimensional point of view. You went through the pathophysiology very thoroughly, the microbiology, the clinical presentation, your emphasis on the multidisciplinary team being needed. And last but not least, I learned a lot of surgical principles. And this is something that's new to me, where the surgeon is aggressive in terms of strategy, when to go in, when to relook, but gentle in terms of technique, the use of minimally invasive techniques. So, as a physician, let me thank you, and also thank clinics for giving us this forum where these important interdisciplinary, multidisciplinary meetings can occur in a very open and collegial way, and where we're still learning a lot from different disciplines, and it can only enrich our own learning and our own clinical practice. So thank you again for this wonderful in-depth presentation. So thank you very much from me, and I'm sure from the rest of the audience as well.
Thank you very much, Prof. Wing. Thanks for those kind words, and thanks to everyone. Thanks, Prof. Koto. Thanks, colleagues who joined us, and the team in the background, Gamo, and the marketing team for the logistical support. And let's have a good evening. Enjoy the address by the President.
Thank you. Bye. Thank you. Bye.
Bye-bye. Thanks for staying until this time.
And thank you very much, sir. Bye-bye.
Bye-bye.